Okay, we're going to talk about rhinoplasty. Rhino means nose, doesn't have anything to do with rhinoceros, except the rhinoceros has a nose, and plasty in Greek means changing the shape, so it's changing the shape of a nose. There are functional rhinoplasties and cosmetic rhinoplasties. A functional rhinoplasty is a rhinoplasty to help you breathe better. And a cosmetic rhinoplasty is a rhinoplasty to help you look better. And there's this other category called reconstructive rhinoplasty that I used to do, which was, taking care of traumatic noses or noses that had cancer, that had part of the nose missing. I used to do big reconstructions for that. But today we're just going to talk about general cosmetic rhinoplasty, plus or minus the functional component of it. So there's two major ways of approaching a rhinoplasty. There's a closed approach and an open approach, also known as endonasal and external. I almost exclusively do external rhinoplasty. There are a lot of reasons why, and you're going to start to understand why that is as we proceed. But I don't like endonasal rhinoplasty. I think there's very little benefit. People always worry about a scar because the external rhinoplasty is right here. That incision heals really well. If you look at my website, you'll see these incisions heal great. And during this video, I think I'll talk to you some of the reasons why I think that incision is so seamless and difficult to see, even close range, especially after everything is healed. So the external rhinoplasty approach is my preferred method. And I'm going to talk about one graft that will explain to you why the external rhinoplasty is so great. And then I'm going to circle around this concept. So the biggest development in the last 2 to 3 years is a migration away from what's called a Collie-Miller strut. So let's talk about this. This is a very complicated subject, but this nose here has no shape, okay? And very little support. And so when you open the nose, you automatically get a weaker structure. The nose becomes weaker. So a lot of people ask, can you just take a little bit off my tip? You can't do that, okay? Every rhinoplasty I do is at least going to take me 2.5, 3.5 hours to work on it, even if I'm just doing a little simple thing, because once you've opened the nose, once you've even done endonasal, done anything there, the nose weakens, the structure collapses. You can't just do that. So it is not such a simple thing. This is for people that are not doing rhinoplasties and they're thinking, can't you just take a little fullness out? To do it right, you either do it right or you don't do it at all. And so once you open that nose, once you make any incision in the nose becomes weaker. So you must make the nose actually stronger. So if the tip is very mobile, okay, and you're worried about how do you make that stronger, well, in the old days, I would put a little bit of the cartilage strut from the septum between these two circles here, and the nostrils, cartilages, and then call it a day. The problem is about a week to a month or 2 months later, the tip would fall a little bit. Not much, maybe 1 millimeter, 2 millimeters, but you know what? That's substantial. If you're thinking about wanting a tip to be exactly where you want it, you don't want that risk that tip will shift over a period of 1 to 2 weeks, 3 months, 2 months. That to me is troublesome. So I've pretty much exclusively, for the last couple of years, abandoned this Collie-Miller strut technique, which is what 99% of surgeons out there do. I use what's called a caudal septal extension graft. Very fancy word, CSEG. What does this mean? So let's talk about it. If this is the septum, which is between the two sides of the nose, that septum is anchored to the skull. It's not moving. It's fixed and strong. That's my anchor point, okay? So I'm taking either some septum, or I may use a cadaveric rib or ear or whatever it may be, but ear is not the best for this. I will then take that septum, extend it caudally, in other words down here, where I can then put my nostrils onto there and support it. Now, there's so many advantages of caudal septal extension graft. One is I can move that tip wherever I want it, and it's going to be exactly where I want it after the procedure's done. It's not going to shift over a period of a week, 3 months. I know where it's going to be. I can see it on the table. There's no doubt. If I don't like that position, I just migrate, move it, and look at it again. If I don't like that, I can reshape it. The other benefit of it, especially in ethnic noses, is something called a lateral tension maneuver. Essentially what that means is, because this point is so fixed and strong, as I move that tip forward, this nostril flare may actually flatten if there's an alar expression where it looks a little wider. So I can adjust this with absolute precision. The other benefit is that as you think about as we get older, the nose starts to drop. Think of Leonardo da Vinci's older men. Well, with the caudal septal extension graft, that tip is firmly anchored there and it's not going to be migrating or going down. I personally believe you really have a hard time doing this with an endonasal approach. With the external approach, you can clearly see your graft, you can clearly see the position, and that's the other thing. When I open a nose, I look at these grafts, they sometimes, the tip cartilage is slightly off. I want to be able to see everything down to minutia. with magnification, making sure the tip looks straight, everything looks straight at the end of the case. So with an endonasal approach, there's a little bit of guesswork. I like no guesswork. I like to see that and get predictability. What is the trade-off of the caudal septal extension graft? The trade-off is that the tip itself will feel firmer. And so it's good and bad. So when you smile, oftentimes the nose collapses. You shouldn't see that anymore. The nose tip will stay pretty firm. The negative is that if you like to play with your nose and press it to your face, you won't be able to do that because the nose will be very firm. It's not any other negative consequence, but I tell all my patients that the tip will be firm to the touch, sort of. So how firm is it? Think about touching the middle of your nose. That's how firm the tip will feel. When you touch your tip, it will be like that. Is that worth the trade-off for all of those benefits? The answer, in my opinion, is unequivocally yes. Absolutely yes. I've been doing this as a standard of care. I think there's all the other rhinoplasties to me make me sweat because there's too much variability. This gives me predictability and long-term assurance that this is durably going to be stable where the nasal tip is. If you can master the nasal tip, you can master the nose. To me, that's the biggest thing. A lot of people ask me, do I break the bones, as if this is the scariest thing in the universe. But the answer is I have to, but I use really tiny instruments. So I've never seen black eyes. I have seen some bruising across here. The reason I don't see a lot of bruising with my rhinoplasty is twofold. I use TXA, tranexamic acid, that reduces bruising potential in almost all my patients. And the other thing that I do is I use incredibly tiny instruments to do the work. The benefit of using really tiny instruments is that there's very little risk of bruising, although there can be bruising. I will not tell you there's no bruising. Do I pat the nose? This is something that people Google and are so fearful of. When I work on the bone movement and when I take a hump down like this, okay, there's going to be a little what's called open roof because I've just taken the hump down. I've got to move the bones in like that. So when I do that, the bones are not quite stable. So for one night, to stabilize the bones, I just leave a tiny pack in there. But to give you an understanding of how little this is, I have two ladies in this past year. One of whom was she actually did a video testimonial, couldn't breathe on her left side. She had a very high deflection on one side. I put what's called a spreader graft to open up that area for her to breathe. But that night, with a little tiny pack in her nose, she said, I can breathe for the first time. So that shows you for how small this pack is, that she's actually breathing better with my corrective surgery and a pack still being in the nose. Those packs come out the next day, you can just pull them out yourself. If you're very fearful, I can take it out, but it's not a big deal. You're going to be oozing for the first 2 to 3 days, it's normal, because your septum, which is what drains a liter of snot, for lack of a better word, that drains back and back of the nose. The cilia in there, if you remember that from high school science, are not functioning well. So that's why you have to wear a little drip pad for 2 to 3 days. There's a splint on your nose, okay, and tape on your nose. And you need to keep that dry for the first few days. So for the first week, so you can tub bathe up to here. You can wash your hair in the sink, but you got to keep the nose dry. I'm going to see you at 7 days, and then I'm going to take the splint off, and then I'm going to be able to apply the tape back on the nose and show you that. So the other thing to know with this is that typically there's not a lot of pain. It's about, most people look pretty good at 7 to 10 days. But over a period of about 1 to 2 years, there's going to be some changes to your nose that may make it look a little better or make it look a little worse. So noses contract over time, especially thick skin patients. I tell my patients to wear a tape at night for the first 6 weeks or so. But over a period of a year, taping the nose is really important because over the period of the first 6 weeks, taping the nose is really important just to keep the skin to sit down well, especially for ethnic noses, which I do a lot of. But over a period of a year, the nose continues to get more and more refined, but also there can be some negatives. Sometimes there's a little bit of a dent or something small that occurs even over 5 years. So I stand behind my work, I tell my patients to come and see me if there's something not quite right. Usually I can just fix it in 2 seconds in the office if something shows up, because remember, the nose is also contracting down. So for the vast majority of my patients, they can see the results at 7 days, even though it's not perfect. The majority of my patients have about a 7 to 10 day recovery period. They should not work out for the first 7 days. After that, they can start going back to a light workout, but no swimming for at least a couple months. No traumatic, contact sports or anything for about 3 months. That's really, really important. And those are probably the key things. Also glasses. If you wear sunglasses or reading glasses, I give you a little headband to hold them for the first 6 weeks. If there's a little dent that shows up after 6 weeks, then I just have you wear it for 2 more weeks and then make sure that's okay. If you're wearing Deciding between glasses and contacts, please wear contacts for the first couple months. It would make things a lot easier if you needed to do that. Those are probably some of the key elements of rhinoplasty. I do a ton of rhinoplasty. I'm board certified in both ear, nose, and throat, as well as in facial plastic surgery. So I'm double board certified for nose treatments. I do a ton of rhinoplasties, a lot of ethnic, a lot of difficult to do rhinoplasty revision cases. So hopefully this understanding some basic ideas of rhinoplasty would help you understand this better.